starting. Please go ahead. Thank you.
Good evening, Doctor. Good evening, respected Dr. M.B. Agrawal, our speaker, Dr. Rajni, and the eminent discussants. It is our pleasure to be a part of such academic endeavor because we believe every moment of life is precious for cancer patients. We are one of the fastest growing oncology company in India. We are having 4 cytotoxic plants dedicated to the oncology with our modern R&D facilities and the modern equipments. Not only this, we are expanding our global presence across the globe. We drive by our guiding principle of patient-first approach because we provide patient compliance with new drug delivery system. We provide patient support, patient education, and cost-effective medicines. In last few months, we have launched 2 major products for the oncology patients. First is azacitidine oral with the brand name of MDS-O, and the second is carfilzomib injection with the brand name of carfimib. With this, I would like to commence the event. I would like to invite to commence the event Dr. M.B. Agrawal. Thank you.
Thank you, Prashant. Good evening to everybody from India, and good morning, good afternoon for those who are logged in from the rest of the world. We have today participation from almost 25 plus countries. Our guest speaker today is Dr. Rajni Priya from Visakhapatnam. She's going to speak on acute promyelocytic leukemia, from highly fatal to a highly curable disease. This webinar is brought to you by Mumbai Hematology Group. It is supported by ADLI and managed by Perfect Square. I thank Mr. Ashutosh Shukla and the team ADLI Oncology, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Rajni Priya from Visakhapatnam, all our discussants who are themselves eminent hematologists or medical oncologists, you participants for sparing your Saturday evening, morning or afternoons. Tomorrow morning at 11:30 a.m., we have our regular webinar, which is on nutrition for hematological malignancy patients. The speaker is from Tata Memorial Hospital, Mumbai, Dr. Shiv Shankar Timanpyati. Tomorrow in the afternoon, being a World Thalassemia Day, we got a long webinar from 3:15 p.m. to 9:30 p.m. The subject is Challenges in Thalassemia 2022, and we have a galaxy of 8 international speakers speaking to us. Discussants this evening once again include very important personalities, and to introduce them to you, Dr. Amita Mahajan from Indraprastha Apollo Hospital, New Delhi, Dr. Asif Iqbal from Bhubaneswar Barua Cancer Institute, Guwahati, Dr. Isha Kaul from Max Super Speciality Hospital, New Delhi, Dr. Gauri Kapoor from Rajiv Gandhi Cancer Institute, New Delhi, Dr. Intajar Mehendi from HCG Hospital, Bangalore, Dr. Jeevan Kumar Garg from Tata Memorial Center, Kolkata, Dr. Krishan Prasad from Mangalore Institute of Oncology, Mangaluru, Dr. Neeta Radhakrishnan from Super Speciality Pediatric Hospital, PGI Teaching Institute, Noida, Dr. Priyanka Samal from IMS and SUM Hospital, Bhubaneswar, Dr. Ranjit Kumar Sahu from AIIMS, New Delhi, Dr. Ritika Khurana from Vijayawada Hospital for Children, Mumbai, Dr. Rupam Deka from Bhubaneswar Barua Cancer Institute, Guwahati, Dr. Satish Kumar from Manipal Hospital, Bangalore, Dr. Shilpa Bhartia from Apollo Hospital, Kolkata. It's my privilege to introduce our speaker for the day, Dr. Rajni Priya. She is MD Pediatrics, DM Medical Oncology. She's a consultant medical and pediatric oncologist at Mahatma Gandhi Cancer Hospital and Research Institute at Visakhapatnam. She did an MD in Pediatrics from Andhra Medical College, Visakhapatnam, and this was followed by DM in Medical Oncology from NIMS, Hyderabad. She received the Abstract Achievement Award by ASH for poster presentation at the annual conference of ASH 2018. She's a member of European Society of Medical Oncology, Indian Society of Medical and Pediatric Oncology, and Indian Academy of Pediatrics. She is author and co-author of publications in multiple national and international journals of repute. She is principal investigator of multiple clinical trials. She is going to deliver her lecture on APML from highly fatal to highly curable disease. Over to her.
So, thank you, sir. Thank you, Agarwal, sir, for the kind introduction. So, first of all, I would like to thank Mumbai Hematology Group, MB Agarwal, sir, and NT Oncology for giving me this wonderful opportunity. So, in the next 40 to 45 minutes, I'll be taking you through the journey of APL, the history of APL, how it has evolved from a highly fatal to a highly curable disease. So, this is the outline of my talk. So, APL was classified as AML M3 in FLAP classification and is currently classified as acute promyelocytic leukemia with T15-17 translocation according to the WHO 2000 classification. APL accounts for about 5 to 20% of AML cases. Once considered the most malignant human leukemia, which is associated with worse prognosis, has transformed in the past few decades into a most curable one. This extraordinary process has been the result of unprecedented coincidence of advances in both biological and clinical research. And today, APL represents a model for differentiation therapy, tailored targeted therapy, and MRD monitoring for diagnosis of early relapses and translational research in general. So this is the first paper on acute promyelocytic leukemia by Hilstead. It was published in 1957, where he observed 3 special types of AML, 3 cases of AML, which are distinct and are characterized by a very rapid downhill course. He noticed in the peripheral smear the predominance of promyelocytes and myelocytes with very few myeloblasts and gave this distinct entity a logical name of acute promyelocytic leukemia. So this is the evolution of APL from highly fatal to a highly curable disease. So it was in 1957, Hilstead identified this distinct entity. In 1973, Bernal et al. Showed that these APL cells are extremely sensitive to anthracyclines. In 1977, Royal showed that this APL is characterized by a characteristic translocation between chromosome 15 and 17. In 1978, Sachs discovered that the leukemia cells could be triggered to differentiate, and differentiating therapies like the first ATRA differentiating agent was first tried in 1985. In late 1990s and 2000, ATRA was used in combination with chemotherapy, and in 2000, ATRA with ATO combination were used and has completely changed the landscape of APL treatment in intermediate risk group patients. Gemtuzumab oxazomicin was also tried in high-risk patients as a cytoreactive therapy, and in 2013, oral formulations of arsenic were also tried in various trials. And in the last decade, there has been no much progress in the field of APL. So coming to the molecular pathogenesis of APL, we all know that APL results from a balanced translocation between the chromosome 17 and chromosome 15. This translocation leads to abnormal fusion protein called the PML-RARA oncoprotein. So this PML-RARA oncoprotein undergoes homodimerization and binds to the retinoic acid response elements, thereby recruiting more and more corepressors, ultimately leading to the transcription repression. This transcription block, this leads to the failure of differentiation. That is, the promyelocytes are not differentiated into the mature forms. Moreover, the hematopoietic stem cells, that is a leukemic initiating cells following the translocation, they retain their blast phenotype. That is, they do not undergo apoptosis. So this molecular pathology formed the basis for the use of differentiating agents, that is ATRA and arsenic. Both of them are the differentiating agents. which bind a different site. That is, arsenic binds to the PML moiety and ATRA binds to the retinoic acid response moiety. Both of them lead to the proteasome degradation of the PML rara oncoprotein. They also lead to the release of the corepressors. They finally leading to the transcription of the target genes, which are involved in differentiation of the promyelocytes to mature forms. This also leads to apoptosis of the leukemia-initiating stem cells. So when you this illustration shows that retinoic acid has predominant action as a differentiating agent with less effect on apoptosis of the leukemia-initiating cells. Coming to the arsenic, arsenic also leads to differentiation, but it has pronounced effect on the apoptosis. That is the reason why ATRA and arsenic agents are synergistic. They are, though they are both differentiating agents, the combination of ATRA and arsenic has shown to have a synergistic effect, thereby improving the outcomes in the treatment of APL patients. Coming to the morphological subtypes of APL, morphologically, APL is divided into hypergranular variant and hypogranular variant. Hypogranular variant is the most common variant, morphological variant, which accounts to 60 to 70% of the cases, and most of the cases present with pancytopenia. The promyelocytes in this variant are characterized by cytoplasmic granules or rods and phagot cells, whereas in the microgranular variant, there is fine granules or absence of these granulations, and this microgranular variant, which is least common, is associated with a rapid downhill course and poor outcomes compared to the hypergranular variant. And this microgranular variant, as opposed to hypergranular variant, usually presents with leukocytosis. Coming to the molecular subtypes of APL, as I've already mentioned, as we all know, it results from the translocation between 15 and 17 chromosome. The breakpoint cluster lesion in the chromosome 17 is always found in intron 2 in chromosome 17, but the breakpoint in the chromosome 15 varies. The 3 breakpoints on the PML gene can occur at intron 6, which leads to the formation of the BCR1 variant, exon 6, which is named as a BCR2, intron 3 variant, intron 3, which is a BCR3 variant. Of all the 3 variants, BCR1 variant is the most common variant. However, the BCR3 variant in some studies have shown to have an aggressive clinical course and poorer outcomes. So these are the variant translocations in APL. So 90 to 95% of the cases have the classical balanced translocation between chromosome 15 and 17. However, in 5 to 10% of the cases, the fusion partner with the retinoic acid alpha receptor may vary. So these are the various fusion genes which have been identified as fusion partners with retinoic acid receptor alpha, and this is important because some fusions, some rearrangements like the PLZF, the STAT5B have shown to be resistant to the differentiating agents. These variant translocations are usually known in the cytogenetic studies. Coming to the FLT3 mutations, the FLT3 mutations in APML is found in approximately 30 to 33% of the cases. Various studies have shown that FLT3 mutation has poor outcome on the outcomes in APL. This is because FLT3 mutation FLT3 mutation leads to ATRA resistance. However, with the advent of newer therapies where ATO is used as a combination with ATRA, we can overcome this FLT3 mediated ATRA resistance. However, as of now, none of the morphological variants or BCR variants or the FLT3 mutations are responsible for any change in our treatment protocols. So none of them influence our treatment decisions. APL, we all know that's an oncological emergency with high early mortality. Early deaths are very worrisome with the acute promyelocytic leukemia. And the most common causes of this induction mortality is attributed to the disseminated intravascular coagulation and the differentiation syndrome. It's very necessary for us to have the prompt recognition of these complications with aggressive supportive measures to improve the outcomes in APL patients. So the molecular pathology behind the coagulopathy of APL is mainly because of three main reasons. APL cells, we all know, which contains granules, is on lysis of these APL cells on spontaneous lysis or after initiation of treatment, really leads to the release of various factors like tissue factor. This tissue factor leads to the activation of the extrinsic pathway of coagulation, thereby leading to widespread thrombosis and consumption of all the coagulation factors, leading to disseminated intravascular coagulation. Other factors like proteases and annexin 2, they activate the fibrinolytic pathway, resulting in hyperfibrinolysis. The cytokines released from the APL cells, they lead to endothelial damage, which further switches the procoagulant phenotype. So this is the mechanisms behind the coagulopathy associated with APL. The ATRA, which is the game changer in the treatment of APL, is not only a differentiating agent in the treatment of APL, but it also counteracts the coagulopathy associated with APL. This is a mechanism how it counteracts the coagulopathy with associated with APL. So ATRA tends to decrease the expression of tissue factor, cancer procoagulant, and annexin to other inflammatory markers which are known to cause coagulation cascade and fibrinolysis. As opposed to ATRA, anthracyclines are known to worsen the coagulopathy associated with APL. That is the reason when chemotherapy agents, that is anthracycline, used alone has shown to increase the risk of bleeding. The reason behind this anthracycline worsen the coagulopathy is it leads to increased expression of the tissue factors, and the RBCs, when they are exposed to daunorubicin, they fit the plasma membrane and expose a phosphatidylserine on the surface, which leads to enhanced binding of the platelets tissue factor, thereby initiating the coagulation event. In addition to them, anthracyclines also lead to endothelial cell damage, thereby accelerating the coagulation. That is the reason why anthracyclines alone, when used in the treatment of induction, leads to an increased risk of DIC. But now, when we are combining ATRA with chemotherapy, the risk of bleeding has come down. So this is one of the mechanisms which can be explained. So how do we manage this coagulopathy? So at the very suspicion, morphological suspicion, the clinical suspicion of APL, we have to start ATRA immediately. Along with the initiation of the ATRA, we have to start aggressive supportive care measures, that is platelet transfusions and FFP and cryoprecipitate transfusion or cryoprecipitate transfusion with the target of fibrinogen above 150 and platelet count of above 50,000. No invasive procedure should be done, especially during the induction phase of the treatment. Coming to the differentiation syndrome, this is another potential life-threatening complication, previously labeled as a retinoic acid syndrome, but later it was realized that it is not only the retinoids which cause differentiation syndrome. Spontaneous differentiation can also occur, and it is also seen with other differentiating agents. Hence, it is labeled as a differentiation syndrome. The incidence is about 2 to 27% with ATRA and 30% with arsenic. Coming to the pathophysiology of the differentiation syndrome, as we all know, the cytokines released from these APL cells, these are the main culprit for the causation of this differentiation syndrome. The release of the inflammatory mediators like the interleukin 1, 6, and 8 in tumor necrosis factor activates systemic inflammatory response syndrome, resulting in the clinical features like fever, tachycardia, and the increased vascular permeability leads to third space losses, resulting in pleural effusions, pericardial effusions, edema, weight gain. The other reasons include release of cathepsin G, which also leads to increased vascular permeability and endothelial damage. Not only this, adhesion of these blast cells may lead to the capillaries, may lead to leukostasis, endothelial damage, and organ infiltration. So that's the reason why we have organ failure, pulmonary infiltrates seen in the differentiation syndrome. So these are the features of the differentiation syndrome, and more than or equal to one feature is termed as differentiation syndrome. Features of more than or equal to 4 features is known as a severe differentiation syndrome. So what do we need to do to prevent this differentiation syndrome? So for all patients who present with a WBC count of 5,000, so this is we have to notice all patients with more than 5,000. The high risk patients include more than 10,000, but we should not wait till the 10,000. For all patients with more than 5,000 WBC count should be started on steroid prophylaxis as a preventive strategy for this differentiation syndrome. So various studies have used various steroids like prednisolone, dexamethasone at varied doses. So the doses of prednisolone can be 0.5 to 1 mg per kg, and it can be started from the day 1 of treatment initiation and can be continued till the end of induction. Some studies have given these steroids for the first 2 weeks of treatment, where the chances of differentiation syndrome are high. Coming to the treatment of the differentiation syndrome, so at the very suspicion of the differentiation syndrome, the dexamethasone has to be given at a dose of 10 mg twice daily. If there is no improvement in the symptoms or signs, it has to be increased to every 6-hourly dosing. Do we need to stop atropine ATO at the earliest sign of differentiation syndrome? Definitely no. Atropine ATO need to be stopped only in patients with severe differentiation syndrome. So along with the initiation of the steroids and cessation of atropine ATO and severe differentiation syndrome, aggressive supporting measures are also required to tackle this differentiation syndrome. Coming to the evolution of the therapy in the APM, that is my topic proper. So this I've already mentioned in the previous slide. We can see from the 1973, where anthracyclines, where monotherapy was used in the treatment, we have evolved to a stage where we are treating APML with the chemotherapy-free regimens, that is ATO and ATRA. So this is the first report by Bernard et al. Who showed that these APL cells have extreme sensitivity to the donomycin, and the use of donomycin in these patients had resulted in complete remissions of approximately 50%. The remaining 50% induction failure were mainly because of the sepsis and disseminated intravascular coagulation. So APL in 1970s were treated either like AML with a combination of anthracycline and cytarabine, or a tailored treatment with only high doses of anthracyclines. So most studies with the use of these chemotherapy have shown to have CR rates ranging from 47 to 88%. And almost all the studies have shown that this is shown to have high rate of fatal bleeding. The mechanism I've already explained in the previous slides, and a lower rate of primary resistance was observed with these APL cells compared with other subtypes of AML. And the lower rates of the primary resistance of these APL blasts is attributed to the low or absent expression of the multi-drug resistant protein called the P170. So these are the various studies where anthracycline alone or in combination with cytarabine were used, and almost all the studies have shown CR rates of 60 to 80%. It was also noted that addition of cytarabine had not resulted in any improvement of the CR rates or improved survivals. So parallel to the use of chemotherapy, there has been advances in the supportive care to tackle the infections and the bleeding manifestations associated with APL induction failure. So significant advances have been made to improve the outcomes with APL. So then there was a question like, what next? After the patient has achieved CR, how do we need to consolidate the remission? So post-remission therapies in the era of chemotherapy alone, that is in the pre-ETRA era, European cooperative groups, bone marrow transplant groups, they trying to consolidate the response remissions with either an autograft or an allograft. And they have concluded that the 7-year leukemia-free survival with the transplantation is approximately between 40 to 50%. So other group, Marty et al., they had tried to consolidate the response with a lower dose of chemotherapy, that is a 6 MPN methotrexate, and it has shown that this low dose, the patients who had received this maintenance therapy had prolonged remissions compared to patients who had not taken any form of therapy. on to the ATRA, which is a game changer in the treatment of the acute promyelocytic leukemia. It was in 1980s when Sam discovered that leukemia cells could be induced to differentiate under the action of certain agents, contradicting the dogma of the irreversibility of the leukemia cell. This retinoic acid has shown to induce morphological and functional maturation of the myeloid cells of the HL60 line. This HL60 line in vitro has common features with the APL cells. And this bedside observation had led to the bedside practice of using ATRA in patients of APL. So this is the first report of efficacy of ATRA, which was published by Meng et al. In 1987, where he treated with 6 patients of APL, and later 24 patients of APL were treated, and he had shown that all the patients attained complete remissions without developing bone marrow hyperplasia. So therefore, the CR rates with ATRA is almost 100% with the use of ATRA in his study. This is another paper by Chen et al. Who also showed that in 50% of the patient treated with ATRA, 94% of the patient achieved CR. So these are the other studies where ATRA was tried in APL, and all of them have shown to have CR rates of approximately 90 to 100%, which is very, very promising. Compared to the CR rates observed with the use of anthracyclines alone, which ranged between 60 to 80%. So, but later they observed that the improvement in the CR rates have not paralleled with the improvement in the outcomes. This is because of the increased relapse rates. Most of the patient relapsed with a median of 5 months. This observation inspired the need for implementation of more modifications in the therapeutic strategies. So then came the idea of ATRA induction, followed by ATRA induction to achieve CR and maintain it with chemotherapy. So there are various trials where ATRA induction followed by consolidation with chemotherapy, that is anthracyclines, have been tried, and they had shown that the overall survivals, the 3 and the 4 year overall survivals were between 70 to 80%. So this is very high compared to the survivals which we obtained with the use of either treatment alone, either ATRA alone or the chemotherapy alone. So this is the first landmark trial. This is the first randomized trial, that is an APL 93 trial, where ATRA plus chemotherapy, that is a combination in the induction, was compared with sequential use of therapies, that is ATRA in induction followed by chemotherapy as a consolidated strategy. Along with this strategy, they even tried to evaluate the role of maintenance in the treatment of newly diagnosed APL patients. So these are the relapse rates for patients who were treated with a sequential approach, that is ATRA followed by consolidation, had more number of relapses compared to patients who were treated in the induction with a combination of ATRA and chemotherapy. Even the event-free survival and the overall survival were better with the combination of ATRA and chemotherapy in the induction. So these are the Kaplan-Meier curves where the raw impact of maintenance on the relapse rates were assessed. So if you can see, for patients who had not taken any form of chemotherapy had more relapses, and patients who had not taken maintenance ATRA had more relapses compared to patients who had taken ATRA. So these are all the arms which showed that patients who had taken some form of maintenance, be it chemotherapy alone or be it ATRA alone, had less relapses or events compared to patients who had not taken any form of maintenance therapy. So patients who had taken chemotherapy and ATRA combination had less relapses compared to patients who had not taken any form of maintenance therapy. So finally, in ELN 2009 guidelines, they had established that the combination of ATRA plus chemotherapy for induction, followed by 2 to 3 courses of anthracycline-based chemotherapy for consolidation, is a new standard of care for the treatment of newly diagnosed APL. Simultaneously, along with the various trials where APL and chemotherapy is being used, Sun et al. From China reported that anti-cancer solution, which is containing 1% of ATO, had showed impressive results of almost 80% CR rates and 30% 10-year survivals with the use of 1% ATO. This paved way for various trials in different parts of the country, world. The first article published in 1988 with the use of ATO and relapsed APL setting. So this is a first trial of APL in relapsed APL patients, where 12 patients, of 12 patients, 11 patients achieved morphological CR and 8 of 11 patients achieved molecular CR. And they have concluded that low dose of arsenic trioxide really does wonders in treatment of patients with relapsed APL patients. This is the other multi-center study from United States, where 40 patients treated with of relapse, both first and second relapse patients, they were treated and 85% of them achieved CR with an 18-month overall survival of approximately 50 to 60%. So this paved way for the use of ATRA in the front line or the newly diagnosed APL patients. Various pilot studies in different parts of the world have been tried. One of it from India by Matthews et al. So have been tried in the upfront setting either as single agent or in combination with ATRA or in combination with chemotherapy from various parts of the world, and showed that the DFS 2 and 3 DFS were approximately 85 to 95%. So this is a single agent of single agent ATO in newly diagnosed APL patients by Matthews et al. So in this paper, the CR rates were approximately 85% and the 3-year overall survival is approximately 85%. So despite the high efficacy reported in various studies, the 2009 ELN guideline did not include ATO in the frontline treatment of APL because of the lack of a organized randomized studies. So the 2009 ELN recommendation was to use ATO only in clinical trials or in patients where anthracyclines were contraindicated in newly diagnosed cases of APL. So then in early 2000, there came the idea of risk-adapted strategies. Do all the patients need to be treated with chemotherapy? Can we reduce the amount of chemotherapy in some patients? And can we intensify the treatment in some patients to improve the outcomes? So this observation by Ginema and Fatima group in patients who were previously treated with ATRA and chemotherapy, they tried to identify certain prognostic factors that affect the survival, and they had given a risk stratification. So this is by Sands et al. From the combined analysis of Fatima and Ginema cooperative groups, he identified the WBC counted presentation and platelet counted presentation had an impact on relapse-free survival. And he had given the risk stratification, which is known as a Sands risk stratification. He classified patients with a WBC count of less than 10,000 and platelet count of more than 40,000 as low risk, with a 3-year relapse-free survival of 98% in the studies, and intermediate risk group patients with a WBC count of less than 10,000 and platelet count of also less than 40,000, with a 3-year relapse-free probability of 89%. Coming to the high-risk patients, all patients with a WBC count of more than 10,000 had a very low 3-year RFS of approximately 70%. So this risk stratification paved way for the risk-adapted management of APL. So this is a comparison of the risk-adapted strategies with the previously done studies. So this is a comparison between the Fatima LPA-99 trial and the APL 2000 trial, where risk-adapted strategy was followed. So LPA-99 trial, if you take, LPA-99 trial used ATRA and hydrochlorobenzene in the induction, followed by higher cumulative doses of anthracyclines in high-risk group, but this LPA-99 has not included cytarabine in the treatment of high-risk groups. Coming to the APL 2000 trial, they tried to incorporate cytarabine in both low-risk and high-risk patients, with high-risk patients receiving higher doses of anthracyclines and cytarabine. So this trial, where they tried to assess the role of risk-adapted strategies, that is intensifying the high-risk group with the cytarabine. So in the low intermediate risk group, they had shown that addition of cytarabine had not resulted any improvement. That is, the APL 2000 trial where cytarabine was used had not resulted in improvement in the survival. But the APL 2000 trial where cytarabine was used in the high risk group had resulted in significant improvement in the EFS and the overall survival. So this concluded that high risk patients have to be treated with higher doses of chemotherapy, that is a cytarabine based chemotherapy. Then the LP99 trial was modified by this Fatima group, and a new protocol incorporating the cytarabine in the high risk group and de-intensifying the lower risk group by reducing the doses of mitoxantrone was tried. That is other risk adapted strategy. So this is a very important landmark trial, that is LPA 2005 trial, and they had shown that this risk adapted strategy, that is reducing the dose intensity or the cumulative dose of anthracycline in low intermediate risk group, had not resulted in any decrease in the efficacy or outcomes, but it has significantly reduced the hematological toxicities and hospital stays associated with the reduction of the chemotherapy agents. Coming to the high risk group, which has received cytarabine, had resulted in improved outcomes with the addition of cytarabine with tolerable increase in the toxicities. So this is a risk model for the risk adapted strategy. Coming to the Genema group, they had simultaneous, coming to the Genema group, they have simultaneously done along with the Fatima groups, and they had also showed that risk adapted strategies compared to the previously done trials, that is, these are the previously Genema trial groups where there was no risk adaptation done, whereas in the IDA 2000 trial where the risk adaptation was done, and they had shown that this risk adapted strategy had resulted in improved outcomes in all the patients across all the risk groups. So this is an consortium of APL 2006 trial, wherein developing countries where the availability of adenosine is problematic because of the cost or lack of availability. It tried to replace daunorubicin in place of idarubicin and evaluate the outcomes. So this is in the developing countries. This study has shown that the 2-year overall survival and the DFS with the use of this international consortium APL 2006 protocol has approximately 80% survivals, and this is on par with the previous trials conducted in the developed nations. And they had concluded that we can safely replace daunorubicin in place of idarubicin in case of its non-availability in developing countries. So in our country, for almost 1 or 2 decades and even till date, many of our institutes use APL 2006 protocol. So this is a game changer in the treatment of APL. This is by Locopo et al. This is an APL 0406 trial wherein the low and the intermediate risk group patients were treated with ATRA and ATIVO. So this is a randomized, well-conducted study where ATRA and ATIVO, which during the induction and consolidation with no maintenance therapy, has been compared with the IDA regimen, that is ATRA and idarubicin in the induction, followed by 3 consolidative courses of idarubicin, ATRA and mitoxantrone, followed by maintenance therapy for 2 years. So this randomized trial had concluded that in low and intermediate risk patients, a 2-year overall survival is approximately 99%, even on long-term follow-up. All the primary endpoints, that is overall survival, event-free survival, and the disease-free survival, were very, very superior with the use of this ATRA-ATIVO combination. Even the cumulative incidence of relapses were also low with this ATRA-ATIVO combination. So this has become the treatment of choice for patients with non-high risk APL. So the practical implication of this trial is that we can safely avoid chemotherapy. So this is a chemo-free regimen given to patients with low intermediate risk patients who are at low risk of relapses, where we can safely avoid the chemotherapy, which is known to be associated with both acute and long-term toxicities. So this ATRA and ATIVO are well tolerable duct, convenient to give and short duration of treatment of approximately 8 months. So the other practical implication is that previously risk stratification was mainly done based on the SANS risk classification. But after this APL 0406 trial by Lococo, the risk stratification has broadly been changed to non-high-risk APL and high-risk APL. For all the non-high-risk APL, we can safely treat them with the chemo-free regimens, that is ATRA and ATO, with improved survivals. So this is an APML4 study. So this is not a randomized study. This is done by an Australasian leukemia-lymphoma group. So where they also even tried to avoid chemotherapy. But in the induction, they tried to incorporate ATRA, ATO along with idarubicin for all patients, and then in consolidation, they tried to avoid anthracyclines or cytarabine, and they tried to consolidate only with ATRA and ATO. This is to decrease the cumulative toxicities of the chemotherapy, and the usage of ATRA may even avoid the need of these consolidation strategies. So that is the main idea behind this APML4 protocol, which was designed by the Australasian group. Even this is followed by a maintenance therapy of 8 cycles. So this study has shown that the 2-year survivals with this regimen is approximately 93%. With the low risk having 97%, intermediate risk with 88% survivals, and 76% in the high risk group. So the results of this APML4 protocol compared to the APML3 protocol or other historical controls is on par. With the other protocols. So even this is a valid and a doable option wherein you can safely avoid anthracyclines in the consolidative phase of your treatment. So coming to the AML-17 study, this is a randomized phase 3 control study where ATRA and ATO was given to all risk group patients. So, but still, this is not a well-conducted study. It has its own flaws. They had concluded that ATRA and ATO regimen had similar outcomes to ATRA and chemotherapy across all risk groups. The main flaws with this study is that it had no maintenance therapy and it has no it does not use any chemotherapy. So further studies are required to evaluate the role of ATRA and ATO in high-risk patients. So still till now, we don't have a well conducted randomized studies in high-risk patients to even take this ATRA ATO regimen and avoiding chemotherapy or with minimal dose of anthracyclines or cytoreductive agents just to counteract the hyperleukocytosis with the differentiating agents. So we may in future we need well-conducted trials in these high-risk patients evaluating the role of ATRA ATO regimens and also a role of maintenance in these high-risk patients. So these are the various randomized trials where ATRA alone or ATO in combination with chemotherapy or in ATO ATRA combination had resulted in CR rates of 90% and survivals of almost 90 to 99%. That is, we have almost reached a stage of curable. So the APML, which was once considered a most fulminant, known to have fulminant course, has changed to a malignancy with the cure rates of approximately 90 to 95%. So this is how we broadly treat the patients. Of high risk, we need to give induction, consolidation, and maintenance. For non-high risk patients, we can just give induction and consolidation and avoid maintenance in this group of patients. So ELN guidelines suggest that as induction therapy for low risk patients, that is for patients with a WBC count of less than 10,000, the standard of care is ATRA and ATO, that is a Lococo protocol, APL 0406 protocol. However, ATRA plus anthracycline is a second option for patients where ATO cannot be given or not available, is contraindicated. Coming to the high-risk patients, there are two valid options, like how we can treat these patients. We can treat with either ATRA or ATO along with minimal amount of chemotherapy, like what was done in AML-17 study or AML-17 study and APML4 studies, or conventional ATRA and chemotherapy-based studies like the LPA 2005 study or the APL 2006 studies. Coming to the consolidative phase, Lococo tried to consolidate with 4 courses of ATO and 7 courses of ATRA with no maintenance therapy in the low and intermediate risk group patients. For patients with high risk high-risk consolidative strategies include 2 to 3 courses of anthracycline-based chemotherapy with the addition of ATRA. However, the role of cytarabine is still debatable, though earlier styles have shown that cytarabine definitely play a role in high-risk patients and patients less than 60 years of age who can tolerate higher doses of chemotherapy. So they most of the regimens include ATRA with 2 to 3 courses of anthracyclines along with high dose of cytarabine in the high-risk group. But when we use ATO, ATRA and anthracycline, the role of cytarabine is debatable. Coming to the maintenance chemotherapy, for low-risk patients, there is no maintenance therapy needed after the conclusion from LOCOCO. But the role of maintenance therapy in high-risk patients, especially after the treatment with ATRA and chemotherapy, has to be continued. That is, all the patients who receive ATRA plus chemotherapy, there is definitely a role of maintenance therapy improving the outcomes in these patients. Coming to the relapsed APL patients, so molecular relapse is defined as 2 successive PCR positive assays which are done with a time gap of 2 to 4 weeks. So identifying the patients in the molecular relapse is very, very important in improving the outcome, because these patients tend to respond very well to a brief course of chemotherapies, and you can take up them for the consolidation. Then for patients who present with a frank hematological relapse, salvage therapy depends on the first-line therapy used and the duration of remission. For example, if the patient had taken ATRA plus chemotherapy as initial regimen, at relapse you can use ATRA plus ATO based approach. If the patient had taken ATRA plus ATO, he can be given ATRA plus chemotherapy. The potential exception for this approach is for late relapses. For patients who are presenting with more than 2 years of remission, you can re-challenge with the initially used regimen. Coming to the consolidated strategies, we can consolidate the second CR with either an autologous transplant or an allogeneic stem cell transplantation. Autologous transplantation is done for patients who are MRD negative. But for patients who fail to achieve a molecular remission, they have to be taken up for the allogeneic transplantation. For patients where transplant cannot be done, we can continue with repeated cycles of ATO, ATRA with or without chemotherapy. So these are the studies where autologous stem cell transplantation has shown to improve survivals compared to the use of ATO alone. So this is other article by the American Society of Bone Marrow Transplantation, where they have shown that consolidation with autologous transplantation is superior to allogeneic stem cell transplantation in terms of overall survival and disease-free survival, but increased treatment-related mortality of almost 20 to 30% with the allogeneic stem cell transplantation. So this is a real-world data Indian studies. So this is a study by Bajpai et al. From AIMS, where the estimated median overall survival is approximately 75%. This is another study by Diana et al. From AIMS, where the 4-year overall survival is 75%. This is a study, this is a long-term outcomes of the use of single-agent ATO in newly diagnosed APL patients by Matthews et al. He had shown that overall survival in the entire cohort is 75%. Coming to the risk stratification, the survival in the low risk group is approximately 100%, but for the high risk, it's only 63%. So they have concluded that these high risk group patients require additional strategies to improve outcome besides the use of single agent ATO. So this is our study from Nizam's Institute of Medical Sciences, which was published in Clinical Lymphoma Myeloma Leukemia. So this is a 1 decade experience of 111 patients at a median follow-up of 34 months. The overall survival is 74%, and the overall survival in the low intermediate risk group is approximately 85%, and in the high risk group, which is 63%, and the results are on par with the other Indian studies. So this is the current management algorithm of IAPL. So this I have already discussed in the previous slide. So briefly, at the very suspicion of APL, ATRA has to be started with aggressive supportive measures, no invasive procedures during the induction. So after we get the molecular confirmation of the APL, so risk stratification should be done. Low intermediate risk groups should be treated with ATRA ATO protocol. For all patients, if until unless A2 is not available or contraindicated, we have to go for chemotherapy in the low intermediate risk group. For high risk patients, we have to treat them with ATRA and chemotherapy. If ATO is available, we can consider as per the APML4 study combining all ATRA and ATO with minimal anthracycline doses, idarubicin or daunorubicin or gemcitabine osagamicin. So bone marrow assessment after induction. Even the recent ELN guidelines does not suggest induction after chemotherapy, and most of the institutions do not practice getting in bone marrow assessment done after induction. Our practice is to get bone marrow assessment and along with MRD assessment at the end of consolidation. Coming to the maintenance therapy, there is no role of maintenance for low risk patients who are treated with ATRA and ATO. The maintenance therapy for patients with high risk who are treated with ATRA and chemotherapy, it holds still good. Coming to the monitoring of these patients, there is no routine monitoring according to the recent ELN 2019 guidelines. No routine monitoring with the RT-PCR for these low intermediate risk group patients on a regular basis. So they have to be just monitored with the CBC every 3 monthly for the first 2 to 3 years. However, the high risk patients have to be monitored with CBC and RT-PCR and bone marrow sampling every 3 months for the first 2 to 3 years. Coming to the future perspectives, so the various phase 2, phase 3 trials, where most of them are conducted in the China, where oral arsenic was compared with the IV arsenic and has shown to have comparable outcomes with the IV arsenic. This is an anticipated algorithm for the APL in future, where it's where we move completely to the chemotherapy-free regimens in all the risk group patients, and we can go with the oral form of treatment, both ATRA and ATO, with just minimal anthracyclines or cytoreactive agents being used in the high-risk patients during the induction phase. So these are my take-home messages. Constant progress in the field of APL has transformed it from a highly fatal to a highly curable malignancies. So the main obstacles with the APL is the early deaths or the induction deaths, which is mainly attributed to the DIC and the differentiation syndrome, which requires prompt recognition and aggressive supporting measures to improve the outcomes. The second obstacle in the treatment of APL is the relapses. So the relapses can be improved by the risk-adapted strategies, that is, identifying the high-risk patients at relapse and treating them with the risk-adapted strategies, that is, higher amount of chemotherapy in these patients to decrease the relapse risks. So finally, MRD monitoring had made identifying the patients early in the molecular relapses and treating them successfully with the therapy and then salvaging with the transplantation had further improved the outcomes in APL patients. So thank you all for your kind attention and participation. Thank you, sir.
Thank you, Dr. Rajani Priya. Hard work, extensive review, very, very impressive from a young budding hematologist from the country. So we have questions from the audience. We have guests here who would like to interact with you. Till they put the raise hand sign, I'll put some question to you in the audience. The first question is regarding intermediate risk. You gave protocols for the low risk, protocol for the high risk. What do you do with the intermediate risk?
Intermediate risk group, now low and intermediate risk group patients are treated with the APL, the ATRA and ATO protocol by the leukaemia. So now intermediate risk group doesn't hold good. So as I've already mentioned, now after the leukaemia trial, now we have only 2 groups, that is high risk and the non-high risk APL. The non-high risk APL to be treated with the chemo-free regimens, ATO and ATRA, with consolidation with ATO and ATRA again with no maintenance therapy. Whereas the high-risk APL patients have to be treated with ATRA and chemotherapy. So our institutional policy is to follow the APL 2006 protocol, but recently with the APML4 study, we tried to incorporate that study in a good number of patients with improved results, where we used ATRA, ATO, and idarubicin in the induction phase, followed with just ATRA and ATO, 2 courses in the consolidation phase, followed by maintenance therapy. So that's the only difference. Now we don't have intermediate risk group stratification and change of treatment.
All right, so Dr. Ruchit Tandon, the answer to your question is platelet count is not important. You just go with low and high risk. That means you do not give arsenic in the induction for high risk, is it?
Yes, sir. So actually, arsenic is not US FDA approved or EMA approved for the use in high risk patients. So it's only approved for use in low and intermediate risk patients because we don't have a well controlled randomized study where ATO was tried in high risk patients. But many of our institutes, like interpreting from the studies like APML4 study, AML17 study, where we have tried ATO in the high risk population also. And even we follow giving ATO in high risk patients, but that too using two differentiating agents. We have to take care of the leukocytosis, the differentiation syndrome, and we need we obviously along with the high risk, along with the use of two differentiating agents, we have to go with the cytoreactive agents. So most of the time we end up giving anthracyclines, either one, like 2 to 3 doses of anthracyclines. So, or we can go APML4 study, which is a well-designed study, sir. So it is after following the APML study, so there is no much issues with the differentiation syndrome or the hyperleukocytosis because they have carefully incorporated the agents like ATA on day 1, 2, 4, and 6. We go with either rubicin or the anthracycline, and from day 9 we start with the ATO regimen. So they will be continued till the CHR is attained.
Excellent. Thank you. Dr. Ali wants to know about the duration of maintenance therapy in the high risk.
Its duration is 2 years, sir. In high risk, 2 years of maintenance with ATRA and 6 MP and methotrexate. So ATRA is given for 15 days every 3 months, and 6 MP is given at a dose of 50 mg per meter square and daily, and methotrexate 15 mg per meter square on a weekly basis. So it's for 2 years.
Do you modify your protocol based on MRD? Duration of maintenance or no maintenance?
No, sir, we don't modify. So that's MRD positive patients. We have to go for transplantation, consolidation.
All right. Dr. Nakul wants to know about any CNS directed therapy.
CNS directed therapy, actually it is described in patients who are high risk and who have CNS hemorrhage at presentation. But during the induction, we should not go with invasive procedures like intrathecal. So usually we can consider for patients in high risk or have CNS hemorrhage, only in those patients intrathecal prophylaxis is considered, or else routinely we don't do. For patients who are asymptomatic or who are CNS negative, we don't go with assessment also, sir. Even the CNS relapses are also very, very rare. The CNS relapse is described at hardly 2 to 5%. So CNS directed therapy, routinely like with intrathecal, we don't go. For high risk, anyways, we are incorporating high dose cytarabine, which is known to have CNS protection. So even ATO has also shown to have CNS protection. So when you're using regimens like ATO or high dose cytarabine, the CNS is also being taken care of. So routinely we don't go with intrathecal or CSF analysis for malignant cytology or intrathecal. Routinely we don't go.
You're still using cytarabine in some cases?
So it's previously when we used to treat with APL 2000 International Consortium APL 2006 protocol, which included cytarabine for high risk patients. Now, as I said, we have moved to the APML4 protocol where cytarabine is not there because we are using ATO and ATRA consolidation. So ATO is an active agent, sir, so we can avoid consolidation with all these anthracyclines and cytarabine. So we have moved from the use of these agents.
Nakul wants to know, for the CNS directed therapy, do you give triple intrathecal?
CNS, as I've said, so routinely we don't do intrathecal. So in case, so like there is no, like we have to go triple IT or intrathecal methotrexate. So
nothing at all. All right.
Routinely practice it.
Fair enough.
So none of the studies have shown that the triple IT is superior over intrathecal methotrexate, even in other malignancies also.
Dr. Tandon wants to know, is there a genetic or molecular basis for hyper versus hypogranular variant?
Genetics, no, sir. There's
Are they molecularly different?
Variant, that's it. So it's not like some molecular.
Okay, fair. And is the bleeding tendency more in hyper, hypo, or both are same?
What, sir?
Bleeding tendency, is it more with hypergranular or hypogranular, or is it identical in both?
So yes, sir. So hyperleukocytosis and bleeding manifestations are more with the microgranular or the hypogranular variant. Both are the interchangeable words. So it's more with the hypogranular variant than with the hypogranular variant than with the hypergranular variant, which is common.
Dr. Ali wants to know, how is the outcome of autologous stem cell transplant? What is the cure rate with autologous in relapse setting?
Yes, sir. So relapse setting, autologous bone marrow transplantation, definitely it has good outcomes. So even it has improved outcomes in patient with relapsed APL patients who are MRD negative. So survivals approximately after bone marrow transplantation is also around 50 to 60% after relapsed cases also with autologous transplantation. So this holds true only for patients who are MRD negative. So the ideal treatment for relapsed cases is to give a brief course of either ATO or ATRA and chemotherapy based on the previous regimen used, followed by consolidation in MRD negative patients with autoimmune.
Thank you. Dr. Rajvarian from US wants to know, does age make a difference on the prognosis? And in turn, then treatment plan of APM.
The studies have tried, even we in our study have tried to analyze multiple variables. So in multivariant analysis, this age had not shown to have any prognostic significance. So we had tried to analyze, and even other studies, so it was not shown to have any prognostic significance.
Dr. Vary, I may just add that dealing with old people, of course, this is a disease of younger people, but sometimes old people, then anthracyclines are out and we are making use of gemtuzumab sometimes. So that is one major difference we do in the practice. Dr. Sain Win wants to know, do you think injection form arsenic can be used? Okay, so is the injection can be given by mouth? The same injectable arsenic?
No, sir.
Right. There is a, I don't know whether it's going on now, from Dharamshala Ayurvedic Center, they are giving oral arsenic
Yes, sir.
to some patients. Is there any correlation between pseudotumor cerebri and ATRA?
Yes, sir. So the side effect described with ATRA is a pseudotumor cerebri. So it requires treatment with acetazolamide or osmotic diuretics, and temporary withholding ATRA can result in improvement of the symptoms. So pseudotumor cerebri, that is a benign intracranial hypertension, is well described with ATRA, the pain can be managed with analgesics like paracetamol, or severe forms of opioids may be required. So it requires acetazolamide, pain analgesics, along with temporary discontinuation of the ATRA.
Thank you. About the APL variants, do you treat them with chemotherapy, or is there a role of ATRA, ATO there also? Variants.
Yes, sir. I've already mentioned, sir, certain variants like which were described, we can go through the literature. So especially the PLZF and the STAT5B, they have shown to be resistant to your differentiating therapies, both ATRA and ATO. So in that patients, we have to go with the treatment with the chemotherapy.
Two more questions here. How do you manage isolated CNS relapse?
So isolated CNS relapse, we have to go with the intrathecal management, that is still clearance we give twice weekly, and then triple IT or IT-MTXL, it depends institutional basis. So always we can prefer triple IT in that case. So weekly twice till clearance, and then weekly once for 4 to 6 doses, followed by monthly once for 4 to 6 months. So this isolated CNS relapse may be harbinger for future hematological relapse. So these patients also need to be treated with your ATRA or ATO. Preferably, I would go for an ATO which has CNS penetration, and then try to consolidate with the bone marrow transplantation. So the treatment is similar to like the normal hematological or the molecular relapse, but we need to even give the CNS-directed therapy till clearance.
Last question is from Dr. Afak, whether you do MRD assessment after induction. Dr. Afak, she mentioned that they do it only after consolidation, not after induction. Okay, we start with our faculty here. Dr. Amita.
Thank you, Dr. Agarwal, and thank you, Dr. Rajni, for an excellent overview. And you did it so comprehensively. I just wanted to know your thoughts. Do you feel even in adults, we will evolve into a maintenance-free regimen even for high-risk patients? Because the pediatric trial that was just published very recently, the AAML1331, it used only the same 4 cycles of ATO arsenic consolidation with no maintenance therapy. And the EFS is in excess of 95 to 96% for both low risk and high risk arms, and overall survival exceeding 98%. So is it something that is being looked at in adults, or you feel that this will eventually find its way? Because after this trial and the outcomes, it seems that at least in pediatric APML, maintenance is redundant.
So the treatment of pediatric APML is similar to the treatment of the adult, ma'am. There is no
In
much.
fact, it's more aggressive. So
Except for the doses
we
of
can get away. Yeah, if we can get away, maybe the adults can get away without it as well.
We apply the same principles because as such APML is a rare malignancy, and that to pediatric population we have very scarce data to suggest. So always we try to follow the principles of the adult APML management.
So Dr. Amita, in adults with high risk, and if we are using GO, then we are not giving maintenance at all. GO is not possible for everybody, it's expensive. So then we liberally use chemotherapy, mainly anthracycline, no cytarabine. And you are right, we are not using maintenance therapy, even with the high risk. We give a total of about 7 to 9 months of therapy and call it a day. Of course, the MRD should become negative after consolidation. Dr. Mehndi.
Hi, sir. Thank you for the opportunity, and thanks, Dr. Rajni. Excellent presentation, comprehensive. I just wanted to know, as you rightly said, because it's a rare malignancy, and all of us who've been managing, like I've been practicing for more than 15 years now. But those who are high risk, some of them may have a relapse, and as you rightly mentioned, CNS relapse is far less common in APML. Predominantly, either we pick them up early at the time of molecular relapse, or they might have frank relapse. Is there a paper describing that at the time of relapse, do these patients still have the similar amount of coagulopathy or differentiation syndrome? Is this risk factor the same? And secondly, what is the published literature globally and as well as from our country on the outcomes of auto and allo in relapse setting?
So actually, I didn't get the question. Actually, somehow it's not audible for me.
Audio is a problem?
Yes, sir. Actually, audio. Actually, I don't know.
Okay. Rajini, one question was between auto and allo.
Okay, sir.
When do you do
At the time
auto?
of relapse, survival data, autologous and allogenic transplant, global literature versus our country published data. And second thing is, at the time of relapse, do these patients still have lot of coagulopathy and differentiation? What is described in literature? I wanted to.
Yes. So that's what I'm saying. Now that we are monitoring the patients with the like RT-PCR on a regular basis, we are finding more number of patients in the molecular relapse. So most of the times we are not waiting for the patients to present with the hematological relapse. Even managing patients who present with the molecular relapse is even more easy. Like it reduces it improves outcomes if you diagnose early in the molecular remission itself. So already I have mentioned that autologous transplantation I will be doing, so not I. So the recommendations are to do only for patients who are MRD negative. For patients who are MRD positive, indicate they are resistant disease and they have to be transplanted with allogenic transplantation. So for a curable malignancy like APML, it's always better to go for autologous transplantation, which has less treatment-related mortality, rather than subjecting for the allogenic transplantation, sir.
Okay, Dr. Yeah.
Thank you, sir.
You have more questions?
No, sir, nothing. I just wanted to add. So for the patients who are still MRD positive at the time of relapse, before subjecting them to allogenic transplant, it would be advisable to bring the MRD to a negative.
No, it's not advisable to get it to MRD negative, sir. If they're MRD positive, we can proceed with the allogenic transplantation.
Okay. Thank you.
Thank you, Dr. Jeevan.
Yeah, thank you, Dr. Agarwal, for the opportunity, and thank you, Dr. Rajni, for the wonderful presentation. So I have two questions. The first question: in your routine clinical practice, are you using both ATRA and arsenic from day one, or you are first start with ATRA and later on you are adding arsenic?
Yes, sir. So definitely for low intermediate risk patients, we are starting Atra and ATO from the day one. And for patients with who have more than 5,000 count, I'll start with the Vicelone as prophylactic agent to prevent differentiation syndrome. So I start simultaneously. But for patients who are high risk, that is who present with high WBC count, and these are the patients where we are more concerned about the differentiation syndrome. So for these patients, we usually start with Atra and then usually give a brief course of chemotherapy. And like the APML4 study I've already mentioned, that is what the study we are following. Even that study had rightly started Atra from day 9. So not all together. So Atra on day 1, 2, 4, 6, 8, we give chemotherapy. And then from day 9, we give ATO.
Okay. So actually, we are using arsenic as upfront. And
we can combine ATO and Atra and start on the same day itself, sir. Because
in low risk category.
Yes, low intermediate risk, whether they have low counts with the present. Most of the APML patients which we see the present with pancytopenias. So starting both the agents is not an issue in low intermediate risk patients.
Yeah, my second question is, you are considering a maintenance treatment post autologous transplant?
What's it?
Post autologous transplant, any maintenance treatment is required?
Any maintenance?
Any maintenance treatment post autologous stem cell transplant?
No maintenance treatment after autologous.
No maintenance.
I would like to ask actually MD Agarwal sir to share his experience, because I had no experience much with the post transplant and all. So still
Rajni, wherever I differ, I have been already mentioned. So if I'm not saying anything, I concur with you. Okay. Even another question?
No, sir. Thank you, sir. Thank you, sir.
Okay.
Sir, मेरा video on नहीं हो रहा है.
Who is saying that? We have not blocked anybody's video. It's problem at your side. Okay, Shilpa, your question.
Hi, Doctor. So actually, one of my questions was about maintenance, and that's already been answered. But yes, it is quite difficult. I think I can just comment because there are many different approaches, and it is about what is feasible. I think no maintenance is the way people are now going to. So my question was about these high risk inductions. You mentioned about a little bit of chemotherapy, a little bit of anthracycline. So what exactly do you mean by a little bit of anthracycline? And secondly, those high risk patients who say presented and, before you get a chance to give them Atra, they had a CNS event or bleed. It's very difficult to give the oral Atra, breaking the capsule and going through the NG tubes. They're not. So would you use, arsenic only induction in such patients?
So as you've mentioned, little bit like that's the minimal anthracyclines that we usually give for patients with low intermediate risk group who develop uncontrolled leukocytosis. That like single dose or 2 doses of anthracyclines if they're not controlled even with your hydroxyurea. So these all are the cytoreductive strategies which we use. So, but for
that is as a part of any protocol, or is that something that we are just using in high risk? We're going to
like AML 17 study where Atra and ATO in all risk groups they have given. So in that study they had used gemtuzumab oxazomycin as a cytoreductive agents. So some trials like AML 17 studies, and some trials like they have used at least 1 or 2 doses of anthracyclines, that is to decrease the cumulative doses of the anthracyclines. But in our practice, we give 4 doses of in high risk patients, not minimal of anthracyclines. We give 4 doses of daunorubicin. Give 4 doses now. So it's 45 mg per meter square, day 2, 4, 6, and 8, or 60 mg per meter square, 3 doses which we give. So in high risk patients, that minimal doses of anthracycline, like 1 or 2 doses of anthracycline, is for the low intermediate risk patients who develop leukocytosis after the initiation of the differentiation.
And then in the high risk, what are you using? Are you going through the chemotherapy consolidation, or you're just going out? Because it becomes a little bit of mixing of protocols, which is very tempting.
Yes, ma'am. It becomes a mix and match. But most of the times, like now that we have so much of data where we can safely avoid chemotherapy with the use of ATO in the consolidation strategies, we can avoid in low intermediate risk, definitely no to anthracyclines. In high risk patients also, we are avoiding consolidation with the chemotherapy. We are just going with 2 courses of Atra and ATO and going with the maintenance therapy. We are having maintenance therapy.
even if like, so Dr. MB sir said, if you're using GO in induction, then we will not be giving maintenance in these high risk patients. However, if we have used anthracycline,
Yes.
you would still go for maintenance?
Yes, ma'am, we go for maintenance in high risk patients, especially Atra and chemotherapy. We have to go with maintenance.
Okay.
Patients.
And the other question was induction
No
bleeds when you
maintenance.
cannot give Atra.
No maintenance for patients who are low risk, treated with Atra and ATO. For patients who are high risk, treated with Atra, ATO and chemotherapy, even though you give ATO and Atra consolidation, we have to go for maintenance therapy. So as of now, we have maintenance therapy for high risk patients.
The second question was about the induction bleeds where you cannot give the Atra. It's difficult to really break those capsule and get the, Atra into them.
We have to give none. So that
No, is there a role of intravenous arsenic at that point as a differentiating agent?
Yeah, we can use that. So we give chemotherapy, and then if the patient improves, then we can go with starting of the differentiating agent.
So Shilpa, here I'll add something.
Yes.
What we do at the moment, and which is being followed now by most of the people in the world, is you have low risk or high risk, give anthracyclines only if you are forced to. And what is meant by minimum anthracycline is just one dose to control the leukocytosis. Otherwise, you give Atra ATO based protocol, assess the patient at the end of consolidation whether your MRD has become negative, and you follow what is called consolidation, not maintenance really, for a period of about 6 more months, total treatment of about 8 months, and call it a day. Don't give any maintenance, don't give any chemotherapy at all. So that's what is being followed because of the use of ATO upfront, which, as she said, is not approved in many countries, and ATO may not be available because of the cost in many countries. We have the luxury of generic ATO, so we have this kind of protocol. Go is extremely effective. So all those patients where they can afford, you must give them Go, because the little bit of relapses that occur, 5%, 10% of patients, early use of Go takes care of it. Later use of Go does not help. So Atra, ATO, whenever possible, Go. MRD after 2 cycles, negative. Consolidate with about 6 months of treatment, about 8 months, 9 months, call it a day. No maintenance irrespective of the risk group. That has become the protocol at the moment. The few variations where the atypical APML, CNS diseases, all those things got discussed automatically. Relapses, molecular, autologous transplant, if bone marrow has been brought into negativity, could not be brought, then allo transplant. Experience with allo transplant in APML is very small because the number of cases are extremely small who really go up to this stage with the high cure rates. So it just now is evolving around Atra, ATO, Go, minimum chemotherapy, minimum maintenance or no maintenance, etc.
Yeah.
What was your exact question about Atra? You are not able to give because of what?
So in induction, supposing a patient has had a CNS bleed and cannot swallow any Atra. So when you do those capsules, the gel in them is very, very difficult to get out and put it through the tube. Okay. So in those cases, when you want to give a differentiating agent, is there, of course, I think I would want to give IV arsenic as my first line up front to try and differentiate the thing. So that was my case. There have been few patients where they've just presented like you cannot give them Atra, but they need something. You can save them still.
Fair enough. I mean, we have had some problem with Atra sometimes, and if again, once the patient could afford Go, we gave Go. If they can't afford Go, then we gave either Rubicin or any other anthracycline. Okay.
You wouldn't give arsenic?
Arsenic is for everybody in my patient.
Okay.
Everybody. I mean, there is no question of not using arsenic. Cost is not an issue, and it is extremely effective. The only way to remove chemotherapy is arsenic. So ATO, Atra is for everybody. Then only you can remove the maintenance phase. Then only you can remove the chemotherapy.
So arsenic is a very good drug, ma'am. So from CMZ Vellore, there is robust data of use of arsenic trioxide single agent in all across all risk groups by Matthew Sir. So it has shown to have good survivals. It doesn't need that. So it's still a practice at CMC Vellore, and some of all our seniors and teachers who have passed out from CMC, they start at ATO. So it depends on institutional practice. Some start with ATRA, and some are more convenient with the use of ATO. So
that was a part of initial trial. Yeah, that was a part of initial trial. Please don't use one drug therapy. It is ATRA plus ATO.
Should not use, ma'am, because in high-risk patients, single agent ATO has shown to have less survival. That is 60% 5-year survival. So for low and intermediate risk patients, we can use ATO single agent. But as you have said, in rare conditions where we come across patients where you cannot give upfront ATRA, so you can give ATO is what I wanted to say.
Okay, move on. Chalo, Ritika.
Thank you, sir. Thank you, Dr. Rajni, for an excellent talk. So in pediatric population, we have seen a couple of patients who have presented with CNS thrombosis in the DIC setting. And we have had really tough time in managing such patients. So ma'am, what would be your advice in, how should we administer anticoagulation to these patients in the DIC setting? And how do we balance that anticoagulation versus DIC?
Agarwal sir, actually some problem with the audio. I'm not able to get the voice.
Yeah, even I could not listen your question. Your question is, how do you manage balance between DIC?
If someone, sir, my question is, if someone presents with CNS thrombosis upfront in DIC setting, how do we give anticoagulation and how do we monitor that in the DIC setting?
So, okay. So presence with thrombosis. There is no role of anticoagulants in treatment of APL because that's a part of the coagulopathy. So thrombosis do occur. And after thrombosis, when the consumption of the coagulation factors, so that the patient will land up in DIC. So when you go on starting with the use of anticoagulants, then you'll be in soup. So because you cannot control the bleeding manifestation. So there is no role of anticoagulants in the management of patients who even present with thrombosis at presentation. So we have to start the treatment with ATRA, and we have to give exercise supportive measures and maintain the platelet counts and fibrinogen levels. So there is no role of anticoagulants.
And presentation with cortical venous thrombosis is an extremely rare entity.
Yes, sir.
Most of them present with hemorrhage. So there are no guidelines. And as she said, you are more worried about hemorrhage than the clot.
Patients present with thrombosis, especially pediatric patients, they are at risk of cortical vein thrombosis. So that will occur, but we don't start with anticoagulation.
Okay. Thank you.
Starting of ATRA and supportive measures will take care of the things.
Thank you. Dr. Neeta.
Thank you. Thank you, sir. Well discussed, Dr. Rajni. So a couple of questions. In refractory patients, patients who don't achieve, have induction failure as such, what is the salvage regimen that you use? And second is the dose.
We'll go one by one. Yeah.
Yes, yes.
You can ask all questions, but one by one.
So induction failure, if patient is high WBC count induction failure, and you've used ATRA plus chemotherapy, what are the salvage regimen that you would use?
We have only 3 drugs, active drugs, like ATO, ATRA, and anthracyclines. So we can go for ATO-based treatment. ATO is a very effective drug in treatment of APL. So if they failed on ATRA and chemotherapy, we can go with ATO. Really, it works well in relapsed or resistant cases. And then we can take up these patients for transplantation. Once they turn, like based on the MRD status, we can plan transplantation.
Next is regarding the dose of ATRA in children. So till what age do you give the lower dose?
Yes,
the PETIMA is 20 years.
So all the pediatric patients less than 12 years, we go with 25 mg per meter square of ATRA doses. So for all the adults and about 12 years, we go with 45 mg per meter square of ATRA in 2 divided doses.
12 is the cutoff that you use. Okay. And last question, when patients come with only thrombosis, CNS thrombosis, do you take them as CNS involved? Like in hemorrhage, you will take them as CNS involved, right? As in so in thrombosis only if they are coming, like with a stroke or a severe cortical venous thrombosis, is that considered as CNS positive?
No, ma'am, that is not considered as CNS involvement. Only like CNS hemorrhage, patients, they are at high risk of having CNS relapses. So these patients may be treated like with either ATO or cytarabine, maybe in the consolidation, or you have to at least after induction get a CSF to look for, because the patient had bleed, to look for malignant cytology, look for involvement in the CNS. So this thrombosis and all are not taken as CNS involvement. Only for patients with high risk or patients with severe bleeding tendencies, we try to rule out CNS involvement. That too after induction we do it. Not during the induction, we don't do any invasive procedures.
Thank you.
Thank you. Priyanka, your question.
Good evening, sir. Thank you. And thank you, Dr. Rajni, for that extensive talk. Recently, we had a patient presenting counts was approximately 1.5 lakhs. He was bleeding, male, 38 years male, and morphology was suggestive of APML. We did a PML RARA, but the PML RARA report was negative. We had started him on ATRA from day one. There was increase in the counts, as we know differentiation occurs. Our flow report was CD34 negative, HLA-DR negative. They were still thinking about a variant form of an APML. But the problem is, how do we counsel? Because, we had sent the cytogenetics. Cytogenetics takes approximately 2 to 3 weeks for us to reach. And when we talk and resend for this fish for the other translocations, that also becomes difficult. And patients in the high risk, having such a high count, sometimes patients also have pulmonary hemorrhage. What to do in such cases? Do we start, even this is a question to Agarwal sir, do we start with the daunorubicin and RSC and then switch over to ATRA-ATO when it comes to the translocation? This patient came out to be translocation 517. So how do we manage such cases?
Go ahead, Rajni.
Yes, ma'am. So these patients can be given anthracyclines, ma'am, and can be waited. So because anthracyclines, like especially for high-risk patients who present with high WBC count, you can give anthracycline at 60 mg per meter square of 3 doses. So.
And second is do you continue with the ATRA, because we know that it is not going to respond well with the ATRA. We have very less data regarding ATO in these atypical transcripts or atypical translocations. So what will be the approach for this patient?
So variant translocations, usually it's better to go with the chemotherapy, like treat them like AML with high dose of anthracycline along with the cytarabine. So for variant translocation, usually that is preferred now. So because the data is as such, as you have already mentioned, it's scarce. So even reporting time also takes time. So even as I mentioned, most of them are resistant. Very few of them are sensitive. So giving ATRA is not of much useful in these patients. So you can treat these patients.
So most of that, what we saw in this case, the bleeding and everything had subsided with the start of ATRA. Possibly he might not have later on responded well to the ATRA or would have relapsed. And Agarwal sir, any of your views regarding ATO in such patients?
So all variant APML are treated with AML protocol, as Rajni said. You cannot take chances of treating them with ATO and ATRA. The data is meager. So you go with exactly as if it was a high-risk AML only. Cytarabine, anthracycline, upfront transplant, everything like AML. It's very clear that there is very little data to show that ATO or arsenic is ATO or ATRA-based treatment is going to be curative in them. So
treat like AML.
It's exactly like it.
Thank you, sir. Thank you.
Satish.
Thank you, Rajni.
Thank you, sir. Thanks, Dr. Rajni. Enjoyed your presentation. My question is regarding arsenic. Patients who are receiving arsenic, if they have a baseline QTC interval prolongation, how do you manage? And how frequently do you monitor the QTC interval in patients who are taking arsenic in the consolidation?
So, as it was rightly mentioned in the ELN 2019 guidelines, the use of Bezet's formula for calculation of the QTC prolongation had resulted in more number of unnecessary, increased prolonged QT interval and unnecessary drug interruptions. So we go with the calculation of QT by alternate formulas, and even then, if the QT is prolonged and more than 470 or 500, we go with temporary holding of the ATO, and then repeat ECG on a daily basis if it's prolonged. If it's not prolonged for patients on ATO, I monitor on a twice weekly basis, along with monitoring of the electrolytes also. The potassium, magnesium also needs to be monitored on a twice weekly basis.
Even during consolidation?
What's that? Yes,
during
sir.
consolidation?
Consolidation, at least weekly once we try to get it done. So during induction, twice weekly, and at least during the consolidation, at least weekly once we ask them to get it. So if it's like prolonged, we hold it, we repeat on a daily basis, and once they have like the QT interval has gone below 450, then we go with restarting of the ATO. So that's it.
Do you see your patients complaining of a lot of body pains, fatigue when patients are in consolidation taking, sometimes there'll be overlap of atra and arsenic. A lot of patient complaints of body pains and fatigue. I just wanted to know, I saw it as an observation. Have you seen patients complaining of just fatigue, headaches? Headaches is known, but severe body pains, especially thigh pains and things?
Not much, sir. So it's a very well tolerable drug. So no much issues with the
Any experience, sir? I don't know. Whenever the overlap is there, they do complain of these side effects. I just give them paracetamol and it goes away. They never have papilledema for me to interrupt atra.
So Satish, fatigue and body
headache is what
pain.
everyone complains, or headache is common complaint rather than the body pains and all. So headache is it's a common complaint. Agrawal sir can add on his experience.
Yeah, so fatigue and body pain has not been the problem. And as I said, that we have everybody who is getting combination. There's hardly anybody who is not getting combination. The symptoms have been more due to atra, the cracking of the lips, the dryness of the mouth, and we have had papilledema, we have had pseudo-cerebral problem, we had frank increase in intracranial tension, we had to suspend atra many times, we had to reduce the doses of atra many times. Arsenic, as you said, we try to keep the potassium above 4, magnesium above 2, monitor calcium, and you can most of the time manage this. And we give this very liberally prophylactically, because we don't want to really interrupt ATO much.
Right, sir.
We have been able to manage most of the patients.
Yes, sir. Yes, sir.
The only addition has been, when the counts go up, 1 dose of idarubicin.
Yes, sir.
As I said, we're liberal, we go for all the fooding patients.
Right, sir. Right, sir. Thank you, sir.
Gauri, your question.
Thank you, Dr. Agarwal. And Dr. Rajni, excellent presentation and excellent handling of all the questions. And I think we have exhausted most of them. I'll have just 2 simple ones. The first is about oral arsenic. As you know, arsenic is now backbone of APL therapy. And during consolidation, giving it IV means that these patients have to come frequently to the hospital. So probably you also are aware that for relapsed APL, people have used oral arsenic 10 milligrams. And what is your take on that? And for Indian patients, wouldn't it be very, very convenient and cheap to take the arsenic at home? So are you aware of oral arsenic coming into Indian market? Or is it already there?
Not available, ma'am. So we are still using the IV form of ATO only. So would like to know from MD Agarwal sir, like in case if he has any experience with the oral forms. So oral formulations are only done in China and they're available in China. Still in US and Europe, the trials are still on. So still now we don't have any approval for the oral formulations. So as of now, I don't think any oral formulations of ATO are available. So sir, your opinion, sir?
Yeah, Dr. Gauri, oral formulation not available. We had approached INTAS for looking into this. They consider APML as an orphan disease. Their market for even intravenous arsenic is so small that they didn't get very excited about producing oral arsenic. They didn't know what the market would be because the data is so small and it's all from China. So how many will be takers? And I think for a curable disease, you don't want to experiment. So even if the patients have to come to institute, take a drip of 2 hours, it's fine. It's highly curable disease, so you don't want to experiment. So we don't experiment at all. Somebody just now asked whether you can give the same injection by mouth. And as I mentioned, Dharamshala, there are people who have been giving arsenic orally to APML patients, and there have been long-term remissions. But this is all anecdotal cases. So in this disease, you don't want to experiment. It's highly curable.
Naturally. No, it has to come in a proper way, not experimenting, not at all. It's such a difficult disease. So the other question is about, we've had a lot of discussion on CNS disease and APL. So Dr. Rajni, you must be aware that I mean, we have already talked that CNS relapse in APL or CNS disease is very rare unless there's been a CNS bleed. And but there is also data which shows that when CSF is analyzed, often promyelocytes are there in a good substantial number of the patients, maybe even 15% or so. But despite not getting CNS-directed therapy, these patients do not manifest with CNS disease at any stage. Is there any hypothesis for this sort of unusual occurrence? I, being a pediatric oncologist, see a lot of ALL. And, ALL, even though there is no CNS disease at presentation, the CNS relapse and the sanctuary site and all. So I was just wondering if you have read anything or there is a hypothesis why, despite being promyeloblasts in the CNS, these patients do not present with CNS disease, leukemia, CNS leukemia.
Yes, ma'am. Actually, we very rarely we come across patients who present with CNS relapse. As I've already mentioned, it's less than 5% even in the high-risk patients. So that to routine for ALL patients, we do routinely do CSF analysis for malignant cytology, but APL patients, we routinely do not do any interventions like invasive procedures during the induction. So even the patient had any hemorrhage intracranial bleed, we don't go about testing the CSF. So I had no experience with the patients presenting with the CSF positive for promyelocytes and later following the patient. So I don't have any experience then because getting the CSF done itself is very, very rare. So following that patients, maybe it's not.
No, this is just from literature. I was just reading up APL and I saw that there were quite a few cases where CSF blasts were present, but they did not require any CNS directed therapy. So either the drugs penetrate well, or I don't know, maybe what is the pathophysiology? I was just wondering, what is the hypothesis for that?
ATO, they are known to have CNS protection, unlike the Atra and anthracycline. So maybe those regimens
Right. Because we hardly ever use intrathecal for these patients. Like,
yes, that's what
I think by default they have so much coagulopathy. Everybody is too scared to give intrathecal, and they are fine without it. So just wondering. Thank you. I mean, you've done a wonderful job.
Dr. Gauri, I don't think that there is a 15% incidence of CNS promyelocytes being present. If this kind of data exists, it is anecdotal data. CNS disease in APML is extreme.
Sir, I will send you the article.
I agree, but this will be taken as anecdotal report. So a word will not agree that 15% of APML patients have detectable promyelocytes in the CSF, number one. Number two, not only you do not do LP, LP is contraindicated in these patients. You should not do LP, even if you have a data like this, 15%. That's number two. Number three, yes, in past cytarabine was there, which will cross CNS. And today you have ATO, which will cross CNS. So that can take care of it, even if there is some subclinical promyelocytes present in the CSF. Lastly, there is a recommendation that all high-risk patients, after their induction, may be given 1 dose every month for the whole of consolidation of intrathecal cytarabine, not methotrexate. And there are centers who regularly for all high-risk do this because the CNS relapses that have occurred in small percentage of patients are invariably high-risk APML patients. So they give, there's no trial or there's no data to go by, but the centers are doing this. The moment patient is into remission, they will give 1 dose every month for the next 8 months of cytarabine. So that's all about CNS disease. And once CNS disease occurs, she has already explained to you how it is treated. Okay, Amita, you have another question?
Yes, sir. 2 brief questions. The first one is about monitoring. So for low risk, I know once we've got MRD negative, we are recommended not to monitor anymore. What is the algorithm for the high risk patients that once you have achieved, after consolidation MRD negativity, what would be your suggested algorithm for monitoring?
Monitoring of MRD for high risk patients.
Yeah. Low risk, we've already completely stopped. High risk, there seems to be a little ambiguity as to.
Yes. So So after the ELN 2019 guidance, we stopped doing, as you have said, for low non-high risk APL patients, we had stopped monitoring with MRD. But for high risk patients, we should get CBC and MRD testing, that is by RT-PCR, quantitative analysis of PML transcripts every 3 monthly for the first 2 to 3 years. Every 3 monthly, ma'am. And bone marrow sample.
Yeah, okay.
Bone marrow sample is what is preferred compared to the peripheral blood sample. So, but really it is very hard in our practice to convince a patient to go for a bone marrow aspiration. So most of the times we end up getting it from a peripheral blood only. So this has to be done every 3 monthly for the first 2 to 3 years.
The other question was that there is, because of the steroids and sometimes prolonged neutropenia, fungal infections still remain an issue, though we don't get much, bacterial sepsis now. So is there any suggestion for what should be, antifungal prophylactic regime, or, whether for prophylaxis or treatment, are there any challenges associated with azoles? Because we've seen marked hypercalcemia in a couple of patients. So should they be, if you're likely to be on steroids for some time, should we put them on antifungals, and what would be the optimal antifungal, and if there's any data of posaconazole like in the rest of AML? So just what is your clinical practice? I don't think that there is any real guideline, but what would be your practical suggestion?
Yes, ma'am. You have rightly pointed out, because we keep on dumping steroids in these patients. So we have to daily monitor the sugars, ma'am. So GRBS monitoring should be done on a regular basis with adequate control of sugars, especially in diabetic patients. And coming to the incidence of fungal infections in these APML patients, yes, we have. So in our institute, we had seen 1 or 2 cases of mucormycosis also in these patients. But the routine use of antifungal agents is only described in AML patients and allogeneic bone marrow transplantation, where the prophylaxis with posaconazole had shown to reduce these infection rate. But routine use of antifungal agents to protect from these fungal infection is not routinely recommended in these patients. Just judicious use of steroids. So you can it's not like guideline where how many days you have to use, because different studies have used different steroids duration. So it's all patient to patient basis, which the optimal or the judicious use of steroids which has to be considered. So we can start with, we have come down to very low doses of steroids, 0.5 mg per kg of Wisdom. We give for the first 2 weeks. So based on the counts, and we decide whether to continue or to stop. Strict glycemic control, which we take care of. So prophylaxis, which we are not routinely doing it now. So in APML, it's not routinely advised.
Dr. Gauri. Okay, the raise hand sign was there, so I asked. Fine, there are no. Do you have a question?
No, I think my query is answered.
Okay, your raise hand sign is still. We have some questions from the audience. Would you like to take them, Rajni? Are you okay taking more questions, Rajni?
Yes, sir, you are there to help me out.
No, sure. So Dr. Vibha Wafna wants to know, kindly outline monitoring during treatment, molecular, MRD, or both. You already answered this, but if you want to just add something. So as she mentioned, 3 monthly peripheral blood for high-risk patients, nothing for the low-risk patient. This is always, we are looking at the PML RARA, and molecular and MRD is one of the same thing. You're not doing flow for this. So here it is only one procedure, one test. The next question is role of cranial radiotherapy for CNS relapse, from Dr. Shilpi Agrawal.
Cranial RT, sir?
Yeah. RT for CNS relapses.
CNS prophylaxis. CNS involvement.
I think it is for the treatment.
CNS prophylaxis. Cranial RT, no, sir.
So cranial artery is not the standard of care.
Only the intrathecal which we use for CNS relapses.
Perfect.
So there is no cranial artery.
Perfect. Dr. Chikodi wants to know how important is the presenting WBC count as the prognostic factor. You have answered this, you can answer again. WBC count at presentation as a prognosis for APML.
Yes, so that is the basis of risk stratification. So previously platelet count was also used by SANS, but now we have moved only with the WBC count in risk stratification. So all those who present with more than 10,000 counts, they are high risk and they have to be treated with Atra plus chemotherapy regimens.
Right, so 10,000 is the cutoff. Okay.
10,000 is a cutoff.
Absolutely. Dr. Arun wants to know molecular relapse definition used in your practice, peripheral blood or bone marrow. She has answered this. Threshold for defining MRD positivity. 1 log increase, or what exactly is called MRD positivity?
So undetectable, it should be undetectable. So any detectable PML-RARA transcript indicates that it's an MRD positive disease.
And the other recommendation is that you repeat it after 2 weeks and show it twice positive before taking a
You have to reconfirm it after like 4 weeks, 2 to 4 weeks.
Okay. And how do you manage microgranular variant of APML? Do you make any differences? Dr. Nupur wants to know.
So this I've already mentioned, sir. There is no treatment change with the morphological type or the BCR variant type or the presence or absence of the FLT3 mutations. So it's only the risk stratification which guides our treatment. So whether it's a high-risk APL or a non-high-risk APL is what matters to us.
Right. So morphology has no impact on the protocol. Only those variants which were described, they will be treated as AML. Tejaswini wants to know, even after morphological CR, RT, PCR is done, at what time should RT, PCR be done, given that PML-RARA may be positive in normal stem cell? So I think one part is, when do you do it? So she does it after consolidation, if that is the question. And second part, I'm not sure. PML-RARA may be positive in normal stem cell. I'm not sure whether that statement is correct. Any literature to show PML-RARA present in normal stem cell?
Sir.
Probably not. At least I'm not aware. Anybody is aware? Okay, we skip this then. Last is role of cranial radiotherapy in CNS. That has been discussed. So that finishes all the questions from the audience. Anything else from people here? Well, then I will be inviting Prashant Agarwal to give the official vote of thanks. But before that, I would like to say that Dr. Rajni Priya, very great hard work done, extensive review of literature, complete presentation, right up to date. And when you mentioned that there was no much research in last 5 years in your beginning slide, that is probably because we have reached the end of the road. Almost everybody is getting cured. So the scope for further research is so little that you are not seeing any much research coming up. China still works on it. This oral arsenic that was discussed by Gauri, maybe it will become a reality one day. That will make life very, very easy for many patients. If we get generic go, that is going to make the life very easy. You will give it liberally to everybody probably, because then you don't have that little relapses left in your protocol, in your treatment. So with that, I'm thanking everybody over here from my behalf. Hand over to, yes, Prashant.
Yeah, thank you very much. And it was a very wonderful presentation and wonderful discussion indeed. And I just thanks once again, Dr. M.B. Agrawal and Dr. Rajni for this wonderful evening. Thank you very much. At the end, ADLE is always in the support of such kind of webinars. And in future also, we will be here to support, sir. Thank you very much.
Thank you. Bye-bye. Good night. And once again, thank you very much, Dr. Rajni.
All the senior teachers and all the hematologists over there. Thank you.
Thank you, everyone.
Great job done. Thank you. Great, great.